My name is Janet Englund, and I'm very delighted to be talking with you today. I wish I was talking with you today in Annecy, but I am very happy to talk to you about one of my favorite scientific topics, maternal immunization in pregnant women. I'd like to say that I have financial disclosures, which are listed here, but importantly, I support flu vaccine and COVID-19 vaccination for healthcare workers, including pregnant women, in my own institution. And I'd also like to say at the beginning, there are many challenges about maternal immunization. I don't have time to talk about all the challenges. They kind of are comparable to Mount Everest. I've been doing this for a while and I've had lots of help from many colleagues over the past years and would like to just list them here. Thank you. So getting going, maternal immunization really is a relatively simple concept. It is giving a vaccine to a pregnant woman to protect her, the fetus, and the infant through active antibody production by the mother and transplacental antibody transfer to the fetus and subsequently the infant. This is not a new topic. It really has been around for a while. The recent history began in the 1970s with routine tetanus toxoid immunization, but by the 1980s, much of maternal immunization had halted, probably because of lack of efficacy data and because in many developed countries, we already had good control of some of diseases such as polio and tetanus. However, in 2009-10, the pandemic H1N1 outbreak really demonstrated the risk of flu during pregnancy and the benefits of maternal flu vaccination for both the women and infants, particularly in industrialized countries that used influenza vaccine. In 2012 through 2015, the pertussis epidemic emphasized the high risk of neonatal pertussis and the benefits of maternal Tdap was demonstrated in the USA and UK. And now in 2020, 2021, the ongoing SARS-CoV-2 pandemic has resulted in vaccine being recommended in some countries for pregnant women. Now, one of the bases for considering maternal immunization is to help protect neonates and young infants. First and foremost, we want to protect the mother. The mother is important. Without the mother, we won't have a neonate. But neonates are uniquely at risk for many infections shown in this slide here. They cause a high amount of morbidity and mortality worldwide. The immune systems of neonates really is relatively ineffective. And active immunization in clinical trials has rarely been successful in neonates. And if I were giving this talk to you in person, I'd ask you, what vaccines do you use in neonates? And I hope you would think about, for example, BCG vaccine. Now, simultaneous with the onset of pathogens that could potentially be protected with maternal immunization, we also are having antenatal care visits among women being an increasing priority in both developing, low and middle income countries and developed countries. I think it's really important to see that it's not, of course, just the number of visits, but the quality of the visits that's important. But there is increased access of pregnant women in many, many locations to prenatal care. So let's get to the bottom line. How does the antibody get across from the mother to the infant, and what factors affect this transport? Well, it's very important to have several things. First of all, a normal placenta is important. And with malaria or HIV, often the placenta is not normal. Time is important. It takes time between vaccination and delivery for the antibody to be made by the mother and cross the placenta via the active transport that occurs. The gestational age of the infant really impacts when and how much antibody gets across, as well as the maternal IgG level and the type of maternal IgG antibody. So how does it actually get across? I have not too much time to discuss this, but on the right, you can see a figure that on the maternal side, there is IgG antibody produced by the mother. This antibody is taken up by the syncytia trophoblasts via an FcRn, a receptor of a neonatal FcRn receptor, where it goes into early endosome phases, crosses through across the syncytia, goes and becomes acidified and is released on the fetal side of the placenta into the fetal circulation at a physiological pH. We know that maternal fetal IgG transport is an active process. It's not just a simple diffusion. It's highly selective. It really only happens with monomeric IgG, and the receptor has to be present for it to be accomplished. And in fact, having a receptor is also very critical for the placenta to function overall. We do think that IgG1 and IgG3 are preferentially transferred, but there is transmission of all IgG subtypes and no transfer of IgM, A, or E. Transplacental transmission begins about 17 weeks, and by 33 weeks, the amount of maternal IgG and fetal IgG are quite similar. By 40 weeks, the fetus has actually accumulated excess IgG, as is seen in the right-hand figure, where you can see more of the dots are above the line of unity, meaning that there's more antibody in the fetus than in the mother. This is actually a very interesting paper from the Netherlands showing that the transplacental antibody transfer by gestational age is very important. If you measure antibody to MMRV, measles, mumps, rubella, varicella vaccine, you can see in infants less than 28 weeks that there really is not much antibody there to these specific vaccines. However, there is some. But if you look at the red line, which is really showing a ratio of 1 in terms of fetal to maternal antibody, you can see that by 32 weeks, it's pretty much 100%, that is unity. But by 36 weeks, there is more antibody in the fetus than there is in the fetus or in the cord blood of the infant than there is in the mother. That's due to active transport. So an abnormal placenta may not efficiently transport these antibodies, and this can be very well seen in this paper showing antibody transfer of vaccines such as Hib, pertussis, pneumococcus, and tetanus in women infected with HIV who did not always have good HIV control. And you can see the reduction of maternal antibody to the fetus ranges from 15 to 40%. So it can be a significant factor. So today I'm going to talk to you about several types of vaccines that are used for maternal immunization, and then briefly mention, of course, some new vaccines that are under development. I think it's really an exciting, developing, and actually now a topic that's being discussed in many places. Start with diphtheria. Diphtheria vaccination in mothers really began in the 1950s. And here's a nice study out of London by a nurse, Molly Barr, and you can see at the bottom of this Lancet paper, it says paper by Miss Barr and others. But she actually was one of the first to document that infants are protected after maternal immunization with maternal diphtheria toxoid vaccines. But when the infants are subsequently immunized, you can see that they have less of an antibody response because they started out with higher antibody and have a less robust response to vaccine. Moving on to neonatal tetanus, this is certainly a preventable disease and has been an important cause of neonatal death worldwide for centuries. In 1961, there was a landmark study in New Guinea that demonstrated the benefit of maternal immunization with tetanus toxoid in a very, very interesting paper, showing there's excellent protection of mothers themselves who are getting tetanus in the birth process due to home deliveries or hut deliveries, and the infants due presumably to some of the cord practices going on then. By 1989, the World Health Organization set the goal to eliminate neonatal tetanus worldwide. This has been expanded and extended several times. And also the methods of increasing the elimination, including adolescent immunization, has actually gone on. We do know that maternal tetanus vaccination is very effective in reducing neonatal mortality. There are not that many studies, but this nice study back from 1980 compared cholera toxoid vaccine to tetanus toxoid vaccine in pregnant women. And if you can look at the bar between days of life 4 to 10, where the red arrow shows, you can see that the deaths per 1,000 surviving children is significantly decreased in the bottom dotted black line when this is mothers who have received tetanus toxoid vaccine compared to mothers who received cholera toxoid vaccine. So as of now, 45 countries have recently, in the past decade, eliminated maternal and neonatal tetanus. We now have about 14 countries left. I'm sure there's some up and some down, but this really needs to be, this needs to continue. And in times of political stress, violence, and disease, it's very difficult to focus on this as much as we should. Going on to pertussis, pertussis really had a big uptick in 2012 in the United States, and similarly in some other countries, including the UK. And this disease burden and mortality was primarily in infants less than 1 year of age, and specifically those infants less than 3 months of age. And this is an X-ray from one of the patients I cared for, who ended up getting ECMO, being in the hospital for a month before finally dying of pertussis disease. In the UK, they also had a big uptick of pertussis. And with this, in both countries, they introduced maternal pertussis vaccine. In the UK, it was introduced as a polyvalent maternal vaccine in October of 2012. And what you can see is that relatively rapidly, probably for several reasons, but mostly linked with maternal pertussis vaccination, the rate of pertussis in infants less than 3 months, which is the top blue line, dramatically fell. The question of when to give the Tdap vaccine during pregnancy continues, and I think there's good data, specifically data by Clarence Seacrest and colleagues out of Geneva, as well as other data from Belgium, Vietnam, Israel, some other great studies showing that really earlier in pregnancy maximizes antibody transmission. And in this time to event graph, you can see at the top line, you want to have more antibody, and you want to have higher levels of antibody. So earlier immunization in the second trimester really seems to be important. What about the impact of pertussis maternal immunization on infants? I think it's really important to know that we must assess the impact of infants' subsequent response to a pertussis vaccine, whether it be acellular or whole cell vaccine. And we can see in this study by Elke Loredan that there is actually good transmission of pertussis antibody in Vietnamese women. What you can see here also is that the persistence of these antibodies lasts about 4 months, and there is some concern of interference with vaccine. We do see lower response rates of DTP or to pertussis antigens after the first several doses in infants at 3 months of age. But what you can see in this bottom graph, or on all the graphs on the far right, is that after the booster dose, following 12 months of age, you can see that there are similar levels of antibody to PT, FHA, and PRN. So with a booster dose, this lower impact of priming, lower impact of antibody is abrogated. In fact, the infants are primed and the booster dose gets everyone up to the same amount. Moving on to influenza. Influenza disease during pregnancy is well recognized as a complication, particularly during women in the third trimester. There is increased severity of disease when there's pre-existing conditions, increased severity with new influenza strains, as many of you who are alive and working during the pandemic in 2009, 10, 11 know. And also, influenza can impact the fetus, not generally by direct infection, but by impacting the mother, which can lead to small infants or small for gestational age infants. A WHO position paper in 2012, based on the data that was available from the 2009-10 pandemic of H1N1, really showed that flu vaccine for pregnant women was indicated based on 3 main factors: a high risk of severe disease in the mother, safety of flu vaccine throughout pregnancy, documented in many countries through many methods, and the effectiveness of flu vaccine in preventing influenza in the woman as well as their young infants. Excuse me. This has been studied in developing countries with 3 placebo or controlled vaccine trials sponsored by the Bill and Melinda Gates Foundation in Nepal, Mali, and South Africa. And what you can see here is that these studies were conducted with slightly different endpoints, timing, control groups, and where the vaccine was given. But you can see here that at least the vaccine efficacy was quite good in Mali and South Africa for women. Nepal, it was slightly less. There's reasons for that, and including the fact that we gave flu vaccine year round instead of just at the flu season, and due to a mismatch of vaccine in 1 year. However, in all studies, including an additional study in Bangladesh, laboratory confirmed influenza in infants was decreased significantly in those babies born to women who received flu vaccine during pregnancy. So there's better protection of infants when there's a good match of flu strains, and you're going to have a lecture or have had a lecture about influenza. This is true with adults, elderly, children, and it's certainly true with pregnant women and their infants. In this graph shown from the Nepal flu study by Mark Steinhoff and colleagues, you can see on the top line with the blue and the red lines that when the flu vaccine doesn't match, the cumulative percent of cases of infants in the placebo group and the vaccine group are similar. However, when the flu vaccine does match well, the green dotted line is the placebo group, and there's more flu cases in infants with the placebo group than in the yellow dotted line, which is the vaccine group. So when the flu vaccine matches, maternal immunization does work. So let's go on to clinical cases. I'm a clinician too. Many of you have some working there, but this is a typical case presentation in an OB or clinic where pregnant women go. Your patient says, I don't believe in vaccines when you offer the flu vaccine to your pregnant patient who's 24 weeks gestation. Last year I got the vaccine and I still got sick. What would your response be? Would your response differ if this woman was pregnant versus non-pregnant? I think it should differ if you're pregnant versus non-pregnant. I do think pregnant women have a higher risk. And I do think that we, the medical community, need to have answers for this. You need to understand what should you say? And some of this can be data-based. There's some good studies out there, how to talk to patients, how to give them facts, how much to argue. But I think it's very important for people to understand that the main reason that women will take up a flu vaccine, at least in the United States, and this has been substantiated with some nice studies in Australia, is to protect my baby from flu. The way you're going to talk to patients about this is that you're giving the vaccine to protect the baby. Protecting the woman is good, but she will not necessarily take the vaccine or be as accepting as she would be for protecting her baby as the rationale. Moving on to RSV, maternal immunization to prevent infant RSV is a very hot topic, and that's because RSV, respiratory syncytial virus, is a very important cause of morbidity and now documented mortality in even full-term infants. We knew before it was important in high-risk infants, but in full-term healthy infants, that is where 75% of the disease is, and it causes a big medical burden, no matter where the baby is. There is known to be efficient RSV-specific antibody transfer to the baby. We've already had good studies 20 years ago showing good immunogenicity when there's vaccination with vaccines that were perhaps not that great. And we've also shown no evidence of teratogenicity in animal models. What has made the RSV field blossom is the fact that we have more understanding of RSV F or fusion protein structures and production. We now know that the RSV F protein has a pre-fusion form on the left and a post-fusion form on the right. And they're very, very different, and they're different immunologically, and they're different in their antibody responses. This conformational change at cell entry really is important for viral cellular membrane fusion. And the activation of this F protein really is a vast structural change. And what we now know is that the pre-fusion F protein is very important in preventing disease. What we also know is challenges remain for maternal RSV immunization. First of all, placental transfer of antibody has to be shown generalizable to all populations. How are we going to deal with women who have HIV or those who have hypergammaglobulinemia? When should we give the vaccine? How safe is a vaccine? And then efficacy. And for efficacy, that requires large controlled clinical trials in geographically diverse countries with developed and developing countries both involved. And the endpoints you choose are critically important and a matter of quite some debate and lots of interest and opinions in the literature. So the first study has been completed. This study was sponsored by Novavax and involved a nanoparticle RSV-F protein. It was not quite a pre-F particle vaccine, and it had pre-specified endpoints set up by the United States FDA, saying they had to get over 60% vaccine effectiveness in infants for this to be considered a successful trial. I will show you some results, but briefly, it did not meet the study endpoints. But what you can see here in these two graphs in this paper led by Shabir Mahdi in South Africa, but with many of us throughout the world involved, is that the red bar, which is placebo, had a lower percentage of of babies with no events. So being on the y-axis, that shows proportion of group with no event. So being lower is bad. The blue bar is higher, both for medically significant RSV and those for RSV LRTI, lower respiratory tract disease with severe hypoxemia. So this really is the first trial that showed effectiveness, not as high as one would have wanted, but effectiveness against RSV in infants following maternal immunization. This was the first study aimed at licensing any vaccine in pregnant women. It was an important first clinical trial that demonstrated safety and vaccine efficacy against LRTI. There are other clinical studies now ongoing by several other companies, and that is really exciting because some of these other trials have vaccines that perhaps are more immunogenic due to further research into the RSV pre-F protein. And these large multi-center, multinational studies, including this one, had very clinically relevant study endpoints. I don't have time to talk about the study, but I hope you're hearing about it at this conference, but it really is an interesting study. The study issues that we and others have discussed include the endpoints, the efficacy goals, how immunogenic was the vaccine, and the fact that apparently there were differences in study efficacy results between different sites, with South Africa actually having better efficacy than the US. A really interesting study. Happy to talk about it more in the discussion. Well, what about COVID-19? I need to make sure that we've discussed this. COVID-19 in pregnancy is now established to be problematic. It can be dangerous. We have increased rates of ICU admission, ventilator use, ECMO or extracorporeal membrane oxygenation, and death in the mothers. We also have some recent paper from international studies, especially this nice prospective cohort study out of 18 countries using a control group of non-COVID-19 infected women at the same time, showing that the COVID-19 positive women had higher rates of complications such as preeclampsia, ICU admission, mortality, and preterm birth. Now, interestingly, the babies did quite well, even though 13% of the infants were tested positive for COVID-19 virus. Really, the babies did quite well and did not have some of these clinical side effects. And importantly, there was no association between exclusive breastfeeding and the baby becoming positive. Really nice paper, just came out recently. So what about vaccines during pregnancy? Controversial depending on where you live. We now have a nice paper showing the preliminary findings of the mRNA COVID-19 vaccine safety in pregnant persons, published in New England Journal of Medicine in late April. This was done by two systems from in the United States. One was an active surveillance study of over 35,000 pregnant participants, of which notably only 827 pregnancy outcomes were reported, as well as a passive surveillance for adverse events, the VAERS system, which I do know you've heard about in this course. The most common adverse event was spontaneous abortion, 46 of 221 reports. But you have to realize this is a passive surveillance system. There's no control group, and of course, adverse events are much more likely to be published. But we do have good safety data. So the risk versus benefit for COVID-19 vaccines during pregnancy. What is important? Well, I don't know, but here's some great ideas. The level of activity of the virus in the community, the vaccine efficacy, the risk and potential severity of the maternal disease, and this can even involve the effect of disease on the fetus, medical and ethnic risk factors and living situations, and ultimately the safety of the vaccine. And this is true for COVID-19 vaccines, RSV vaccines, Group B strep vaccines, all the vaccines that we're talking about. So moving on, we do know that Group B strep vaccines are also being investigated. We have a new study out, I believe that's very recently, showing on the right-hand side a new hexavalent Group B strep vaccine in non-pregnant individuals, which looks like it should cover 98% of Group B strep strains, which is really exciting. Perhaps we can be moving on to Group B strep immunization of pregnant women too. But we have obstacles for maternal immunization. We do have a lack of effective vaccines against many important common pathogens. There are huge liability issues that affect the interaction with pharmaceutical companies and their desire to test and spend a lot of money on large clinical efficacy trials. The immune response to some of the vaccines we use, including pertussis, is short-lived, necessitating intrapartum vaccination and perhaps repeated immunization, as we in the US do against pertussis. And We have monoclonal antibodies as an alternative for this. We could have long-acting monoclonal antibodies, perhaps, to give early in birth. And finally, and this is not to be minimized, there are huge and important regulatory and legal issues at multiple levels. So I would like to conclude now with the take-home messages. Maternal immunization is not new. Maternal immunization is safe for the mother and the infant with several vaccines that have been tested in many, many women. Maternal immunization can protect both the mother and the infant. And an example of that is influenza vaccine that has been studied in many countries around the world. Benefit to infants against protecting RSV have been shown in the very first placebo-controlled RSV maternal immunization trial. And maternal immunization has the potential to address other important maternal neonatal pathogens. With that, I would just like to conclude by saying that maternal immunization is increasingly appreciated and utilized worldwide. It's really an important tool, something we need to study, and it's becoming such that we're going to have to figure out how many vaccines can we give to whom, when, and how. Can we give 2 vaccines at a time, 4 vaccines at a time? How many will women even accept at one time or during pregnancy? This is going to be another area that we're going to investigate. So thank you very much. And with that, I will be around for questions. Thank you.